All right, welcome to the Explainer. Today, we are going to tackle a big one, calcium channel blockers. We're going to break down everything you absolutely need to know for the NCLEX, how they work, the different kinds, and the critical must-know nursing responsibilities.
So let's just dive right in. DHP versus non-DHP. I know it sounds super confusing, and honestly, this is a topic that trips up so many students. But I promise you, by the end of this, you are going to have it down cold. We're going to make this really, really simple.
Okay, so first things first, let's get down to the basics. Just think about it. What does calcium do in the body? It makes muscles contract, right? It's like the go signal for muscle cells. So if these drugs block calcium from getting into the cells, well, what's going to happen? You get less contraction. You get more relaxation. That is the core idea behind every single calcium channel blocker.
So, where exactly are these drugs doing their thing? It's not just in one spot. And for the NCLEX, you really need to know the 3 key places they work, because that's what explains everything, all the therapeutic effects and all the side effects we're about to get into.
And here they are. First up, the vascular smooth muscle, basically the muscle lining your arteries. When you block calcium here, those arteries relax and widen. That's vasodilation, and poof, blood pressure goes down. Second, you've got the cardiac myocytes. Those are your actual heart muscle cells. Less calcium here means a less forceful squeeze. That's what we call a negative inotropic effect. And third, there's the cardiac nodal tissue, your SA and AV nodes, the heart's electrical system. Blocking calcium here slows down the heart rate, a negative chronotropic effect, and slows that electrical signal as it travels, a negative dromotropic effect.
Okay, this next part, this is probably the most important distinction for the NCLEX when it comes to CCBs. They are not all created equal. They are split into 2 major families, and it all depends on where they like to work. Getting this right is absolutely key.
So you've got 2 teams here. First, you have the dihydropyridines, or DHPs. Think of these as vascular specialists. Their main job is to relax those blood vessels, which is fantastic for hypertension. Then you have the other team, the non-dihydropyridines, or non-DHPs. These guys are more focused on the heart itself. They work on the heart muscle and that electrical system, which makes them really useful for controlling things like atrial fibrillation on top of treating hypertension. And here is your golden ticket for remembering these on the exam. It is so simple. If the drug name ends in DIPINE, like Amlodipine, Nifedipine, you're dealing with a dihydropyridine. That's your DHP family. The other 2 you just have to memorize are Verapamil and Diltiazem. Those are your non-DHPs. Seriously, lock that DIPINE trick in your brain. Okay, now look closely at this chart, because this is where it all comes together. See those bottom 3 rows? The DIPINEs pretty much leave the heart's rate, contractility, and conduction alone. But look at Verapamil and Diltiazem. They decrease all 3. This is exactly why they're used for arrhythmias, and it's also why they come with a much higher risk for things like severe bradycardia and heart block. It all makes sense when you see it laid out like this. All right, let's put on our nursing hats. We're at the bedside now. You've got the medication in your hand. What are the absolute non-negotiable things you have to check before you give any of these calcium channel blockers?
Before you even think about giving this med, you've got to check those vitals. First, blood pressure. A systolic under 100 is a huge red flag. You're going to hold that med and call the doctor. Same goes for the heart rate. If it's too low, especially with the non-DHPs like Verapamil, you hold it. And just as important, you have to look at that EKG. If you see a 2nd or 3rd degree AV block, that's an absolute no-go for the non-DHPs.
Okay, so you've given the med, but you're not done yet, not by a long shot. Now you're monitoring. You have to be vigilant for any signs of worsening heart failure. We're talking crackles in the lungs, new swelling or edema, because remember, these drugs can weaken the heart's pump. And you'll also watch for those common side effects, like peripheral edema, that puffy ankle look, which is super common with the DIPINEs, and constipation, which is a classic side effect of Verapamil.
You know the NCLEX loves to test patient teaching, and for good reason, right? We're not just giving out pills. We're trying to keep our patients safe after they go home. So let's talk about the crucial things you need to tell your patient. The number 1 thing you have to tell them about is orthostatic hypotension. Because these drugs relax the blood vessels, their blood pressure can just plummet if they stand up too fast. The instruction is simple, but it is so important. Change your positions slowly. Go from lying to sitting, wait a minute, then from sitting to standing. It prevents falls.
Okay, here's a weird one, but trust me, the NCLEX loves to ask about it. Gingival hyperplasia. That's a fancy term for overgrowth of the gums. It's not super common, but it's a known specific side effect. So you've got to tell your patient how important it is to have really good oral hygiene and to see their dentist regularly.
All right, everybody, listen up. We are now entering the red flag zone. These are the big-time dangers, the interactions, the things that can get a patient into serious trouble. If you only remember one section from this whole explainer for your exam, make it this one.
Imagine this. You're doing your discharge teaching, you're feeling great about it, and then your patient says this: I'm going to start drinking healthy grapefruit juice every morning. Your internal alarms should be screaming. This is a classic NCLEX trap, and that statement needs immediate correction.
So what's the big deal with grapefruit juice? It's not just some old wives' tale. It actually blocks the specific enzyme in the liver that breaks down these medications. So if that enzyme is blocked, the drug just builds up and up and up in the bloodstream, leading to toxic levels. We're talking severe, life-threatening hypotension. It is a huge no-no.
And if grapefruit juice wasn't enough, we've got another major player you have to watch out for: digoxin. Some calcium channel blockers, especially Verapamil, can actually cause digoxin levels to rise. This can easily push a patient from a safe therapeutic dose right into full-blown digoxin toxicity. So if your patient is on both, you have to monitor them like a hawk.
So you have to empower your patient. You need to teach them exactly what to look out for. The earliest signs are often GI-related: nausea, vomiting, maybe they just lose their appetite. But the classic sign, the one everyone remembers for exams, is the visual changes, seeing those weird yellow-green halos around lights.
And this number right here? You've got to know this for your exam. Digoxin has a super narrow therapeutic window. The sweet spot is between 0.5 and 2. Anything over 2 is considered toxic. It doesn't take much to get there, especially when a calcium channel blocker is in the mix.
All right, let's put it all together with one last NCLEX-style challenge. You've got a patient taking Verapamil. That's a non-DHP that slows down the heart's electrical system, remember? And now their EKG shows a complete third-degree AV block. What is your absolute first priority nursing action? You've got to think through the drug class, its specific effects, and your role. The priority here is to hold that next dose and notify the provider immediately. That's how you keep your patient safe.